From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
I'm Dr. Kristin Walter, Associate Editor at JAMA and a pulmonary critical care physician. I'm joined today by Dr. Peter Mazzone, who is a pulmonologist and director of the lung cancer program for the Respiratory Institute at the Cleveland Clinic in Cleveland, Ohio. We will be discussing the article he wrote, along with Dr. Lewis Lamb, a pulmonologist at the Cleveland Clinic, entitled Evaluating the Patient with a Pulmonary Nodule, a Review. This article was published in the January 18th issue of JAMA. Thank you for joining us, Dr. Mazzone.
Thank you very much for the invitation.
So to start with some basic terminology, can you define a pulmonary nodule for us and explain how it differs from a pulmonary mass?
Yeah, of course. A pulmonary nodule has been defined as a focal, distinct radiographic density. Usually in the definition, it also says completely surrounded by lung tissue. And the only reason I highlight that is sometimes a nodule can be right against the edge of the lung. You might argue it's not quite completely surrounded, but we'd still consider that a lung nodule. The difference between a nodule and a mass is really just based on its size. So anything less than 3 centimeters in size is considered a pulmonary nodule. Bigger than 3 centimeters is a pulmonary mass.
And your review focuses on patients with a solitary pulmonary nodule or a dominant pulmonary nodule if there were multiple nodules. Can you describe what types of pulmonary nodules were not discussed in your review?
Yeah, of course. We chose to write about a dominant pulmonary nodule because that's the most common thing you'd have to manage in your clinical practice. It's also the situation where your main question is this lung cancer or not? But there are other situations where you might come across a patient who has a pulmonary nodule or nodules that weren't discussed in this review. For example, some patients have multiple pulmonary nodules where there isn't a dominant nodule. Some patients have a pulmonary mass, and we didn't choose to discuss these because the question and the management is quite a bit different. With multiple pulmonary nodules without a dominant pulmonary nodule, you're wondering, is this infectious? Is it non-infectious inflammatory or metastatic disease? Pulmonary mass, the likelihood of malignancy is so high that your management approach may differ. And finally, we didn't talk about managing even a dominant nodule in somebody who has a known cancer. So they're actively being treated or they just completed treatment for a cancer. Because your question there is really, is this nodule related to that cancer? And so the approach would be quite different.
And in the U.S., approximately how many people are diagnosed with pulmonary nodules on an annual basis? And what % of chest CT scans detect a pulmonary nodule?
Yeah, it's a good question. It should be very easy to answer, but there are a few nuances or caveats to it. The study that we quoted most in our review, the one that we feel is best done, looked at a cohort from a health system of individuals who had CAT scans done of their chest through the years. And they looked at the radiology reports and said, how often does the radiologist report there's a lung nodule there, any size? And the answer was 31% of the time. Extrapolating that to the U.S. population, you'd anticipate about 1.6 million individuals are diagnosed with a lung nodule every year. The only reason I hesitated and said that there are some caveats is if we think of how that study was done, those individuals were getting scans for any reason, and 31% of the time they were found to have a lung nodule that was reported by a radiologist. When individuals have a CAT scan done with the purpose of looking for a lung nodule, like in a low-dose CT lung cancer screening program, oftentimes you'll see reported higher numbers. If you count any size lung nodule, oftentimes over half of individuals who had a low-dose CT screen will be found to have at least one lung nodule.
So clearly pulmonary nodules are common and certainly can be anxiety-provoking to patients. But to put this diagnosis in perspective, what % of these pulmonary nodules are actually benign?
This is also very important, and it helps to frame really the goals of managing a lung nodule. A full 95% of all lung nodules identified on chest CAT scans are benign. So we think of a goal in managing lung nodules as being, hey, let's find that lung cancer as quickly as we can. But given that so many of these nodules are benign, there is an important secondary goal, and that is let's not overtest, particularly with invasive testing, those individuals who have a benign nodule.
And can you discuss briefly what the most common causes of non-malignant pulmonary nodules are?
Yeah, as most of those are never biopsied or resected, for an individual, we may not know why they had that nodule, only that it's benign. It has features that suggest it's benign or it never grew. In general, we say the most common reason someone would have a benign nodule is that nodule is a small granuloma. So it's a little bit of area of inflammation and scarring related to exposure to a prior infection, often an endemic fungus in the area that they live. Or maybe it's a small intrapulmonary lymph node. There are other less common causes of benign nodules, a hamartoma, an arteriovenous malformation being some that are discussed.
And in terms of epidemiology, can you discuss who's at higher risk of developing pulmonary nodules when you consider the categories of age, sex, and smoking history?
Yes, of course. Two of them are quite simple. For age, the older you are, the more likely it is that a scan done will find at least one lung nodule. The more you've smoked, the more likely it is that you'll be found to have a lung nodule. The sex question is a little bit more difficult. It's fairly even, and there's some variability in the studies. If you had to fall on one side and say perhaps slightly more common in women than men.
And are there certain occupations or geographic locations within the US that are associated with a higher risk of developing a pulmonary nodule?
Yeah, there is some evidence that individuals who've done a lot of farm work or individuals who have a history of hard rock mining have a higher incidence of having lung nodules on their imaging. In terms of geographic location, areas where there is endemic fungi, such as the Ohio River Valley for histoplasma and the Southwest US for coccidiomycosis, tend to have a higher incidence of having lung nodules found.
And which medical conditions or diseases, apart from malignancy, are associated with increased risk of pulmonary nodules?
The most important one, the most common one that's discussed is chronic obstructive pulmonary disease. And this is particularly important because having COPD is also a risk factor for having lung cancer. So now you have individuals who, independent of their smoking history, are more likely to have a lung nodule. They have a higher risk of having a lung cancer. And the evaluation of those nodules can be a bit complicated by their underlying pulmonary disease. So the most important one to keep in mind is COPD.
And just shifting to the nodule itself, what are some features of a pulmonary nodule that makes the diagnosis of malignancy more likely?
So when we look at the imaging, we're looking for features that help us to answer that question. The larger a nodule is, the more likely it is to be malignant. Nodules that are in the upper lung zones have a higher likelihood of being malignant than those in the lower lung zones. And the shape, and particularly the edge characteristics of the nodule, if it's a nice smooth bordered nodule, a lower chance of being malignant. If it's irregular, or the term used spiculated, little tendrils coming from the nodule, then it's a higher likelihood that nodule is malignant. Final thing we look for is growth. If we do have serial imaging performed, if the nodule is growing at a pace in keeping with cancer, that's a very, very important feature as well.
And that leads to my next question, which is, other than size, are there certain nodule features that make malignancy less likely?
Yeah, absolutely. One of the ones that I highlight to keep track of is the nodule calcified? In particular, is there a benign pattern of calcification in the nodule? Benign patterns include dense central calcification, laminated calcification, stippled or popcorn patterns of calcification. That is a very sure feature that the nodule is benign, and you don't have to test it further. The other I mentioned briefly is if you have serial imaging, is the nodule growing or not? If the nodule hasn't changed its size in 2 years, you can be quite confident that that nodule is benign. There are other less common features of a nodule, but some that can really help you out. If the nodule has varying densities within it, in particular if there's some fat density within the nodule, then it suggests that nodule is a hamartoma, a benign lesion that can obviate the need for further evaluation. Another feature you might see is a vessel entering into that nodule and another leaving the nodule, suggesting the nodule is an arteriovenous malformation, which you'd manage differently than if you were worried about it being a lung cancer.
Oh, that's very helpful. I'm going to move on to the concept or the topic of solitary pulmonary nodules, which are considered to be small in size if they're less than 8 millimeters in diameter. What factors should be considered when deciding how these patients should be followed up with imaging?
Yeah, this category, the small solid pulmonary nodule, is the largest category of all of these lung nodules we're talking about today. Very, very common to find them. And the two things I would keep in mind when deciding how to manage those, one is its size within that range of less than 8 millimeters. Is it less than 6 millimeters or is it 6 to 8 millimeters? The other is whether the individual with that small solid lung nodule or pulmonary nodule, whether they have any lung cancer risk factors. Have they smoked cigarettes? Do they have a family history of lung cancer and those such things?
And that leads me to the next question about some general guideline recommendations for the American College of Chest Physicians when they talk about small solid pulmonary nodules.
Yeah, so there are some well-written guidelines that help us when managing individuals with these small solid lung nodules. To summarize those, they suggest that nodules smaller than 6 millimeters should be monitored with a chest CT scan in about 12 months' time if the individual has any lung cancer risk factors. If they don't have any lung cancer risk factors, then that nodule would be of such low risk that additional follow-up isn't required. For a nodule between 6 and 8 millimeters, the recommendations are that you have a chest CT scan in about 6 months' time. The guidelines have evolved to give some flexibility to the provider and the patient. So you can include other nodule features other than just size. You can include your own gestalt and your preference, as well as your patient's value set when making decisions. So instead of just 6 months, it may say 3 to 6 months. Instead of just 12, it may give you a little bit of leeway by saying 6 to 12 months.
And your review also discusses larger solid pulmonary nodules, which are those that are 8 to 30 millimeters in diameter. The risk of malignancy in these nodules is higher than in the small pulmonary nodules, but still has a wide range from less than 1% to greater than 70%. What are the factors that go into deciding the type of follow-up that these patients should have?
Yeah, I think it's very important to understand why we distinguish these two, the small solid pulmonary nodule and the larger solid pulmonary nodule. And you highlighted one of the important factors is that the risk of malignancy tends to be greater in these larger nodules. In addition, the value of extra testing tends to be greater. So our additional imaging or biopsies tend to have a better yield for these larger nodules. So whereas we only monitor the smaller low-risk nodules, here there's lots of options and some nuance to their selection. So what we use to help us decide is an estimate of the risk of malignancy based on patient and nodule characteristics like we've discussed, and also an understanding of the tests and tools that are available to us. How accurate are they? How well do they apply to this individual and this particular nodule?
So I guess that leads me to the next question, which is the pulmonary nodule risk calculator. Is there one of them that's better than another for predicting malignancy? And should different calculators be used for different populations of patients who have pulmonary nodules?
Yeah, that's a very important question. There are several risk prediction calculators available, and they're well established. They've been validated. Their accuracy is fairly well known. As you might imagine, from any calculator building or model building, those models tend to perform best in populations similar to which they've been developed. So, for example, one of the most common calculators used stood the test of time. It's called the Mayo Risk Calculator, and it was developed on nodules identified first on chest x-rays. So the nodules had to be large enough to be seen. So they were 8 millimeters or bigger. Well, if you applied that calculator to a very small nodule found in a screening population, you may end up overestimating the risk of malignancy. The Brock model is a model that was developed in a screening population, and so can be very accurate in those small screen-detected lung nodules, but may underestimate the risk of malignancy in a larger nodule that was identified in a different way. So in general, the risk calculators that are available are well validated, excellent to use to help guide you. But understanding the population that they were developed in may help you to apply one in one setting and another in another setting.
And are there low-dose CT scan prediction models for malignancy that are separate?
Yeah, so there are models that can predict the risk of an individual having a lung cancer that might help you to guide them as to whether to be screened or not. And then separately, there are models that are developed to help you assess the risk of a screen-detected lung nodule. The one that's most commonly used, and we discuss in the review, is called the Brock University model.
And your article discussed dividing larger pulmonary nodules into 3 risk categories: low risk, which would be less than 10% risk of malignancy; intermediate risk, 10 to 70% risk of malignancy; and high risk of greater than 70%. And those patients should generally be recommended to go for surgery if they're fit and willing to undergo surgery. So I just wanted to break them down into categories. So starting with the low risk, larger pulmonary nodule, that is less than 10% risk of malignancy, and for which a chest CT is selected as serial follow-up. What is the recommended time for these patients, the interval between CT scans?
Yeah, so for this size range, the larger solid pulmonary nodule that you've estimated the risk to be low, less than 10% as the example, the recommendations are to follow that nodule in 3 months with a chest CT scan. And 3 months is selected because it's enough time that the average growth rate of a malignant lung nodule will show enough growth to be noticed, but it's not so much time that you fear a lung cancer escaping your attention.
And then those patients who have a larger pulmonary nodule with an intermediate probability of malignancy, falling into that 10 to 70% range, a non-surgical biopsy, such as a CT-guided transthoracic needle biopsy or a guided bronchoscopy, may often be offered. Can you discuss the yield of these procedures?
Yeah, so the yield for diagnosing cancer in a malignant nodule of either transthoracic needle biopsy or guided bronchoscopy is reported to be in the 70 to 90% range. There are some factors that may make that average yield different for your individual patient: the size of the nodule, the location of the nodule, the presence of an airway leading up to the nodule are the things that might affect that yield and help you to decide which of those non-surgical biopsies is most appropriate for that individual.
Can you discuss potential risks of CT-guided transthoracic needle biopsy or guided bronchoscopy?
Definitely the most common risks of those procedures, the ones that are important to discuss with our patients, are anytime you do a biopsy in the lung, whether it's through the needle or through the bronchoscope, there's a risk that the lung can partially collapse, so a pneumothorax can develop. The second most common complication is bleeding or hemorrhage. Both of those are quite a bit more common in transthoracic needle biopsy than they are in bronchoscopy, but they're important risks that need to be discussed for either of those procedures.
And another important point in your review is the concept of individualizing care and how 2 pulmonary nodules with an identical probability of malignancy may be managed differently. Can you elaborate on that?
Yeah, I'm really glad you asked that question. I was afraid that message may not come out well as much as we tried to make it clear. This really is something that I'd love the readers to take away from this. There are guidelines that provide you with recommendations There are fabulous radiologists giving you reports with recommendations, but they're not sitting there with that individual. They may not know if that individual has had prior imaging done somewhere else, or if they have a history of a distant cancer that might influence things. They may not know that person's value set. They may not know about their comorbidities. All of these factors are taken into account when deciding what the next management step should be. And so we try to highlight that very much here. In addition, even if you had two identical individuals who both had a nodule that had a 30% probability of malignancy, the location of that nodule, its size, may guide you one way or another. It may say that a transthoracic needle biopsy is going to be more likely to give you the answer, or a bronchoscopy. So both patient characteristics, an extensive look to make sure there aren't old images, an understanding of that patient's symptoms or what led up to that scan, all of these things influence management of individuals with lung nodules, as well as an understanding of what test is most likely to give you a high yield and be safe for that person.
That's very interesting. So far we've been talking about solid pulmonary nodules. I'd like to shift to subsolid nodules, which is the other type of nodule that was discussed in your review. And those are considered either part solid or pure ground glass. Can you define the term ground glass for us?
Sure, yeah. Ground glass means a haziness, or you are able to see the lung architecture through the nodule on the images. Particularly, you might see the blood vessels within the lung. It's almost like, looking through a church window. You can see through it, but it's kind of hazed for you.
And how does the growth and risk of malignancy compare between solid and part solid nodules?
So the cancers that appear as a subsolid nodule, either a ground glass or part solid nodule, tend to be in the adenocarcinoma spectrum and tend to grow rather slowly. So you do have more time to make good decisions, and you also commit yourself to following those nodules for longer periods of time than you would a solid nodule before you can confidently say that they are not malignant. If you had a part solid nodule that has a solid component of 6 millimeters, and you have a solid nodule that's 6 millimeters, the probability of malignancy would be higher in that part solid nodule.
And then you talked about the risk of malignancy and the growth that may be slower. What about a pure ground glass pulmonary nodule? How frequently are those patients developing cancer, and how often should they undergo follow-up imaging?
So given the slower growth rate of a malignant pure ground glass nodule, interval for follow-up is a little bit more spread out than what we talked about for solid nodule, and the length of time is longer. So if you have a pure ground glass nodule that's less than 6 millimeters, additional testing is not required. Very, very low risk. If it's greater than 6 millimeters, then recommendations suggest another scan in 6 to 12 months. And if that nodule hasn't grown, then every 2 years until you've watched that nodule for at least 5 years. And if it hasn't grown at that point in time, you can have an informed decision with your patient about whether additional follow-up's needed or not. If you're following somebody with a part solid nodule, we follow that based on the size of the solid component. If an individual has a part solid nodule where the solid component's less than 6 millimeters, we recommend follow-up in about 6 months' time. If it's between 6 and 8 millimeters, then in about 3 months' time. Larger than 8 millimeters, and I would behave towards it just as you would a larger solid nodule.
When would you recommend that a primary care physician consider referring a patient with a pulmonary nodule either to a specialist or a multidisciplinary pulmonary nodule specialty clinic?
In general, the blanket statement that applies to most things we deal with would be anytime someone's uncomfortable with what the next step should be, you're uncertain about the next step, then please do refer on. Separately or more specifically, it might suggest that the nodules that have a higher risk of malignancy or the care is more nuanced get referred. So a solid pulmonary nodule that's greater than 8 millimeters or a nodule in the subsolid category, I would also consider referring to a specialty service.
And can you tell us about multidisciplinary pulmonary nodule specialty clinics? How common are they, and how are they typically staffed, and what are some potential benefits of these clinics?
Yeah, multidisciplinary pulmonary nodule specialty clinics have been growing in their numbers and their place here. And I think it's for a few reasons. One is we all fear that somebody's going to have an X-ray or CAT scan of their chest for a different reason. A nodule's found, but it's not the focus of the person caring for the individual at the time. Maybe they came to the emergency department or they were hospitalized for something, and that nodule can be missed and an opportunity to manage it appropriately or find an early lung cancer can be lost. Separately, as we've talked about, there is some very nuanced care decisions that have to be made in managing someone with a pulmonary nodule. And so having folks who have expertise in that team up can be very helpful for patients. But usually there's a way to identify that individual, perhaps a flag in the radiology report that a nodule was seen, or the use of a linguistics program, natural language processing that can pull out the word nodule, identify a group who's been identified as having a lung nodule and feed it to that program. The program they may then consist of advanced practice providers and specialists, pulmonary specialists, thoracic surgeons who have an interest in lung nodule care. It usually includes care paths, communication tools with patients, and oftentimes even a tumor board type setting where difficult decisions are made as part of a team to help direct patients. The value of that sort of a program is you do everything you can to make sure a lung nodule is not missed, and there's a bad outcome because of that. You ensure compliance with follow-up as much as possible, and you ensure that you're providing appropriate guidance about how aggressive management should be. So in that setting, instead of following an excellent radiology recommendation, you may be able to discover other factors that would influence a decision, and you can stray from recommendations with an outcome being better for the patient, less testing, earlier diagnosis of cancer.
So patients often have distress and anxiety upon learning that they have a pulmonary nodule. Can you discuss the importance of shared decision-making?
I'm really glad you asked this as well. It is a very important part of lung nodule care. Many times a person hears they have a lung nodule, and what registers with them is, I have lung cancer, even if it's a 3 millimeter, extremely low risk lung nodule. I've had patients delay their visits so they could have their wills updated, and their lung nodule was extremely low risk. Also, we may make recommendations based on what we think is best for an individual. Oftentimes, it's not a black and white decision. It's, should I biopsy or follow something in a few months? And understanding the patient's value set, understanding what's going on in their life can help you include them in that decision in a way that leads to the best patient-centered outcomes. So shared decision-making should be part of every lung nodule management visit.
And what do you see as potential future directions in diagnostic testing for lung nodules?
It really is an exciting time. I hope that new tools that are being developed will be able to really help guide us, allow us to predict the risk of malignancy, the aggressiveness of that malignancy more accurately over time. Two that I would mention. One is the use of artificial intelligence to look at the nodule on the imaging. There are some studies suggesting greater accuracy with artificial intelligence platforms than clinician estimates or traditional risk calculator estimates. There is still some work to do to make sure that those accuracies are validated and they're clinically useful, but it's an exciting area. The second is the development of molecular biomarkers, so blood tests looking at circulating tumor DNA changes, proteins, autoantibodies, metabolites, and so on. or tests of other cells in the body that can help us to better estimate the risk of malignancy in an individual and therefore make better decisions for them. These tools are near future tools, and I think in the next 5 years or so, it will really start to influence the way we manage patients with lung nodules.
Is there anything we haven't discussed about pulmonary nodules that you'd like to mention to our JAMA audience?
I don't think so. I think your questions were really comprehensive. I think no matter what type of practice you have, you're going to see individuals with pulmonary nodules. I hope that you have tools or teams available in your area that can help you. And if not, you have regional centers that can help you if needed. And I really appreciate the opportunity to share this information with everybody.
That was Dr. Peter Mazzone, a pulmonologist and director of the Lung Cancer Program for the Respiratory Institute at the Cleveland Clinic in Cleveland, Ohio. Thank you so much for sharing your thoughts about this very interesting and important topic. This is Dr. Kristin Walter. Thank you for listening. This episode was produced by Jesse McQuarters at the JAMA Network. The audio team here also includes Daniel Morrow, Shelley Steffens, Lisa Harden, Audrey Foreman, and Mary Lynn Furkaluk. Robert Golub is the Executive Deputy Editor for Digital Media. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com. Thanks for listening.